chair, co-chairs, and moderators and friends. I will be speaking on pediatric cataract surgery in challenging situations. While these children come to us, we have to examine each of the child. Majority of the children, they come with visually significant cataract. And then we have to examine each of the child after dilatation, that which type of cataract is there and what should be done. Then only then you can find the difficult situations. And what is our goal of pediatric cataract surgery? Goal is to find a clear visual axis and visual rehabilitation. That is the long-term visual rehabilitation. And then I will show some of the situation. First I will be showing normal pediatric cataract where it is a zonular cataract. What we have to do? We have to diagnose, plan, innovate, execute, and find out the complex pediatric cataract and operate them and have long-term follow-up of these children. First, I think I would like to show a small clip of zonular cataract. This is a child with zonular cataract, classical zonular cataract. To demonstrate, I think, or otherwise also, stain the anterior lens capsule with the trypan blue dye and make continuous curvilinear capsular axis. Size of the axis is kept around 5 millimeter or so. If you try to make large, it will be very large. So make precise about 5 to 5.5 millimeter axis. Hydrodissection followed by removal of the cortex from the capsular bag, and then usually in children less than 6 years, sometimes even less than 8 years, we make primary posterior capsulotomy. Size of the primary posterior capsulotomy is kept around 3 to 3.5 millimeter. If you make very large, it will be difficult for you to place the IOL. So here we are trying to make about 3.5 millimeter axis, and then you do limited anterior vitrectomy in the zone of axis, then implant hydrophobic acrylic IOL in all cases. Previously we used to implant even PMMA IOL, sometime even now, but majority of the cases is hydrophobic acrylic IOL. So this is after surgery, and don't forget to place suture at the main incision. Then comes pediatric complicated situations such as PHPV, posterior lenticonus, ophthalmos, juvenile idiopathic arthritis, uveitis. Here is one child with classical posterior lenticonus. Here I have done anterior segment OCT, which shows that there is a posterior capsular tear, and then making continuous curvilinear capsular axis. Then limited hydrodissection. If you do very vigorous hydrodissection, you will find you will create more disturbance, because there is a already PCR, posterior capsular rupture. So here I have done more carefully, and as expected there was a PCR, and then IOL is implanted into capsular bag. And whatever I think vitreous is there in the this site of the rupture, pre-existing rupture, that is cleaned, and surgery ended with and this is 8 months after clear visual axis. This is anterior segment OCT. And then comes another child with juvenile idiopathic arthritis having 360-degree posterior synecdoche. In such situation, synechotomy is done and then place Malaysian ring or any other device to adequately dilate the pupil. But we must know that how to place this Malaysian ring. This is easy to place, not difficult. Staining was done, and this is continuous curvilinear capsulorhexis. This is phacoaspiration. It actually you can do with the IA also. And here is placement of IOL in the capsular bag. And sometime in such patient where there is 360-degree posterior synecdoche, we do a small peripheral iodectomy. Not in every case. Then come this child with congenital lenticular coloboma. Here it is not question of placing the IOL, it is a question of stability of the IOL bag complex, what we ultimately want to achieve. So here in this situation we have to place capsular hook. These are the capsular hook, and then synecdoche was also removed, and then removal of the cortex from the capsular bag. And this is for stabilization of the capsular bag. This is a pair pack suture, and this is a single eyelet Sioni ring which is placed in the capsular bag, and it is now it is the final position where we will place it. And then this is in this case, because toric IOL was placed, this is Callisto we are using. And final position of the IOL, and this is after removal of the hooks. This is before and after surgery. This anterior segment OCT also. So here this third child come this with double crystalline lens. I think you must have seen this video at many of the places. This is a child who had united cornea, two cornea joined together. There was junction in the center, and there were two crystalline lenses. They were separate crystalline lenses, and we planned a customized IOL for this child. And this was a 18mm long customized IOL which was made by Care Group. Actually, you will find hole in the haptic, because I thought that if I fail to do place the IOL, then I will do transscleral fixation of IOL. Second choice was also kept. This child could see. This was a long-term follow-up video. Amblyopia therapy was given. Child is seeing through the affected eye. You can see the cornea, how it looks like. Then comes another difficult situation, or where we say persistent pedal vasculature, or we also say primary PHPV. Rhexis is made, then cauterization of the vascularized membrane, and then we have to make capsulotomy and place IOL. Difficult to cut with the vitrectomy cutter, but it is quite thick membrane, and this is cauterization of the stalk, and removal of this stalk so that there is no bleeding after cauterization, and placement of IOL, because it may be difficult to place IOL directly into bag, so it is captured, optic is captured into capsular bag. these are some of the other, these are animations and some of the other classical cases of PHPV which we have operated. And these are other situations, and these are some of the publications. Lot of number of children they are operated and documented. And this is to show one child operated in 1997. That time it was just starting of primary prostate capsulotomy and anterior vitrectomy, and this is followed for 25 years. In 2000, only last year, he got he completed his MBBS. He is a doctor. He is a E-metro. He is myopic by I think 1.25, 1.5 diopter. So long-term follow-up is important. Just in shortly, I will tell some of the proudest moment. This will take not more than 1
Dr.
minute.
Jagat Ram, Chikitsa Netra Vigyan.
And received Best of the Best award at ACRS, 2 times winner award 1 time, and Oscar of Pediatric Ophthalmology. So this was also proudest moment for me. Thank you very much for giving me this opportunity. At present, this is after retirement. I am working here at Grewala Institute.
Thank you, sir. Thank you for your excellent presentation and the vast variety of videos which showed all types of pediatric cataracts which we deal with as pediatric ophthalmologists. Sir, anybody has any questions for sir? Anyone who wants to ask something?
So, do you have an age cutoff when you will implant an IOL after pediatric cataract surgery?
Yeah, definitely. Those first we have to find out that which cases are fit for implantation of IOL. Ideally, it is 6 months or so. That less than 6 months one may not do, or one has to be very careful. Although I have operated even 1-month-old child, and I have followed that child for long time, more than 15 years, because if there is no microphthalmos, axial length is more than 16.5 or 17 millimeter. If it is a unilateral cataract, even less than 6 months we implant IOL. But where there is a contraindication, I think you should not implant.
So I agree with sir, especially in unilateral cataracts, you can think of lesser than 6 months. For after 6 months, every child should be implanted with an IOL, provided there are no contraindications, there is no microcornea, there is no microphthalmos. The bag has to be there. Otherwise, you'll have to get a custom for the double thing. Otherwise, obviously, you cannot induce secondary glaucoma. That is the biggest risk which we have if we implant a normal size IOL in a pediatric age group with a smaller. So that is the first thing. So second, because I had done it as my own thesis, I remember. So what is your take on doing posterior optic capture in very, not very young children, obviously, because there I would prefer to do an anterior
PCO?
Yeah. No,
Yeah.
so
Posterior optic capture. Most commonly I do in the bag implantation of IOL. That is number one. Almost 85 to 90% I do in the bag. Sometime there are optic capture 2 type.
yes. So I'm
One
talking the
is
posterior optic capture.
posterior capture. Posterior capture means that your IOL
It's going behind-
haptics
behind
are
the-
in the bag and optic is behind in the posterior capsule.
in the anterior
That I do less than 1% or so. That is also excellent.
So
But
actually, what were my experience in my own thesis, and I still
Yeah.
follow that, was that very young children, obviously the vitreous is very active. So in those, even in my, like it was exactly the Gimbel's technique which I had followed. And in that, what I had done was we had compared 2 cases where we had not done vitrectomy and where we had done
yeah,
without
that
vitrectomy,
will
we had done posterior optic capture, and in the other group we had done vitrectomy.
Yeah,
So the one with the vitrectomy obviously will not have the vitreous obstruction.
Yeah.
But the age group was a very important aspect in this. The children who were younger, less than 3 or 2 or something like that, they all, despite a posterior optic capture but no vitrectomy being done, they developed a piece of opacification of the intervitreous space, which did not happen in the other group, which are older.
Yeah.
So that's why doing, you can do without a vitrectomy in older age group, but obviously PCC is a
Yeah,
mandatory,
definitely.
and optic capture helps in that, in which the basic thing is that the size of the IOL and the size of the posterior rexis in that case has to be very accurate. It has to be only 1 millimeter overlap, less than the size of the overall optic of the lens of the PCC, so that it leads to a very, very tight apposition between the posterior capsules to prevent the migration of the lens epithelial cells into the vitreous cavity.
Now I fully agree, and even we do primary posterior capsulotomy less than 6 year or more less
that
than
we're doing
8
in
year.
almost every
But even then, don't say that 100% people
no,
will be
100%
having
not.
clear
I
visual
can
axis.
understand.
Even then, children get PCO.
Yes,
There
vitreous
will be
spaces.
ACO. There will be some
AC,
membrane over the IOL surface, and there may be PCO. 10-15%. Still, they will get.
And sir, another thing, what is your take on putting IOLs in the patients with JI? Juvenile idiopathic arthritis.
Juvenile?
Idiopathic
Yeah.
arthritis.
One case I showed, that is fine. But otherwise, we have to be very, very careful that which type of inflammation is there, whether it is a recurrent or which type. So very carefully, it is a very controversial also. And prognosis remains, it has improved because we place IOL and we deal under follow-up, and because they may get recurrence or they may get glaucoma, chances are very, very high. But one has to be very, very careful. If you are experienced, careful, and then I think one can
So
go
would
ahead.
you do a PCC in these cases? Would you do a PCCC in these cases, posterior rexis?
Yeah, no, in the bag implantation of IOL.
No, in the bag is okay, but would you be doing
Primary posterior capsulotomy,
yeah, primary posterior
surely,
rexis you would be doing.
surely, sure.
So because I have seen, like I have operated several cases of JI, but recently I had a case which after doing posterior rexis, I don't know whether that is the reason, but he developed severe vitritis, severe optinitis for 6 weeks. He was perfectly fine. After 6 weeks, he landed with severe inflammation. He had to shift it to biologicals. He was on methotrexate when he came to me for surgery, and he's shifted to biologicals. Then he developed immune keratitis with the biologicals. So he has kept on developing one or the other immune complication. One after
They
the
are
other.
very, 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 very carefully we have to do. I don't say that 100% we want to, we have to take consultation from our uveitis clinic people also.
Rheumatology people.
One should not think that I know everything.
No, no,
I
sir,
may not
rheumatology
know
people have
because
to be
they may, rheumatologist also,
yeah,
because very
rheumatologists have to
difficult
be there.
situations. No, the excellent question. Actually, I had 2-3 video that is beside the point. I thought that I will show one video, and those band-shaped keratopathy. I have all the videos. Even there, our uveitis clinic people, our consultant will say to inject Azuredex injection, Dex implant, and these patients are followed by us and them also, our vitreoretinal and uveitis clinic people. So this is a truly out of all the cases, this is one of the most difficult situation. One has to be extremely careful. I don't say 100% that okay. Whatever you do, I think initially for few months it will be fine. Afterward, there will be lot of issues. I have few documented cases and full of pediatric JIA type of inflammation, classical. But here I have shown only one case. Okay, thank you so much.
The main thing is